for joining tonight. This webinar is on the introduction to subchondral solutions, presented by Dr. Derek D. Genesis Orthopedic Partners is sponsoring the webinar. To those who don't know about us, we are, in essence, we'll give the short explanation. We are a commercialization entity that specializes particularly in the areas of sports medicine and foot and ankle. So with our team of myself, Ben Coburn, Josh Bigney, and Tim Huber, we have collectively about somewhere between about 45, 50 years of experience commercializing different foot and ankle and sports medicine products. So with that, we'll go ahead and jump in. Dr. D, do you want to go ahead and introduce yourself and your background, and then I'll go ahead and jump into the presentation from there.
Sure. Thanks very much, Ben. Thanks to everyone for helping put together this presentation, for having me on this. So we're going to talk about the S-Core implant system. I'm in private practice for 18 years. I'm on the West Coast in California. I did some arthroscopy and sports fellowships and did most of my training out here. Just a brief agenda. I'm gonna cover some of the science and the background underlying the design of the implant and the technology. We'll talk about some sports medicine applications, foot and ankle applications, adjuvant procedures, and then we'll conclude. So the cartilage subchondral bone interface is designed specially to dissipate forces from the joint. Very little of the shock from the joint is absorbed by the cartilage. Most is transmitted through the tissue, and the undulation of the base plate adds surface area to this and also serves to convert these shear and tangential stresses to compression as much as possible. Bone is stable in compression and typically fails in tension and shear. So it's a very specialized unit. We know that the bone, subchondral bone, the osteochondral unit, we call it, is a functional unit both structurally and metabolically. There are penetrations into the base plate from nerves and vessels. About 50% of the metabolic support of the overlying cartilage comes from the bone itself. And so the disease involves both failures structurally and metabolically. You can get micro cracks early on and cystic changes. Eventually, the bone becomes sclerotic and interferes with the vascularity. This is a source of pain, and the degeneration continues. These are some close-up images of how the bone will continue to respond to abnormal stresses by Wolff's law. This is bone hypertrophy. Sometimes we call that intralesional osteophytes, but you can see on the image on the left how the bone will grow up into and encroach upon the real estate of the cartilage. On the image on the right, this shows bone hypertrophy in the close-up, but also more significant damage to the bone, an osteochondritic or osteochondrosis situation, which also can occur with bone failure. The image on the left, again, it reemphasizes the communication and interplay between the overlying cartilage and the bone. And the radiograph on the right shows this bone hypertrophy that we've all seen as the disease progresses. And this image here just demonstrates that the potential healing of a cartilage layer, the red, follows a different temporal course and is independent from the bone. And in this model, where they crisscross is where that bone starts to grow up into and interfere with cartilage space. This is from a study that summarizes some of the changes that happen in osteochondral disease. You can get the bone hypertrophy, microcracks, trabecular fractures, and architectural changes and cystic changes. These are some of the current options many of you are familiar with that each have their own advantages and disadvantages and drawbacks. overall, we're looking for a procedure that is versatile and strong and is able to address the subchondral bone. This is the Core HA implant. It's hydroxyapatite coated. It has fenestrations that allow marrow communication and bleeding to occur through the implant. It's chambered on the inside, so it's both bone preserving and further allows communication from the marrow contents up through the implant. And we're approved for bone fixation. The implant comes in a variety of sizes. You can see the aspect ratio is they're not particularly long, but the aspect ratio is nearly 1-to-1. But it comes from it ranges in size from 4 to 10 millimeters. They are titanium and plasma HA coated. The instrumentation is typical to a guided cannulated screw. You've got our cannulated countersink reamer, and we've got this coring reamer. You can see in the side view, the coring reamer preserves this central post of bone, and then you see the implant there. This is a short animation of just the steps of the procedure. This is in a smaller bone. You can see the countersink coming from the side into this in situ fracture, basically placing into the center of the defect. And that's our coring reamer, which cuts and clears the bone. It allows some good bleeding to happen while preserving that central post of bone. And then the implant is, the screw is placed over the guide wire to the crept depth. It's deeper than this. This diagram implies it's relatively superficial, but it's actually countersunk into the bone. The Core HA implant may serve as a procedural platform, so to speak. And the idea is that, number one, we're fixating and stabilizing the bone, but with the fenestrations and biochannels, it may allow access to further biologics or scaffolds. And the hydroxyapatite coating creates a bioactive surface that improves osseointegration. This was a biomechanics study done that combined the implant with a dermal allograft. And this hybrid reconstruction was tested in the elbow joint, the radiocapitellar joint, with 8 and 11 millimeter capitellar defects. And contact pressures were measured in different forces. And it showed that after the reconstruction, joint forces were able to be normalized to towards the intact condition. So this is a time zero demonstration of what this particular construct can accomplish. Overall, we often are thinking of cartilage and bone anatomically as separate. As I've demonstrated it, they really act as a unit. And so then what is the diagnosis? And you can have acute overload, which I would call this like a fracture situation, patellar dislocation, ACL tear, where you have the osteochondral defect or a fragment. And then we have situations where there's repetitive stress and what I call generalized overload that over time may then result in some of these other sequelae. In my mind, the disease is osteochondral disease or osteochondrosis because we know that the body's unable to heal this and progression continues. This is just an algorithm of treatment that I put together. Just it's basically taken from Ortho 101, which is fracture, fragment, fixation. You have in situ fixation. You've got fragment reduction, internal fixation, complexes versus simple fractures. The diagnoses, the potential diagnoses at the top, bone edema, trabecular fractures, osteochondritis dissecans. And then we just follow the pathway of treatment down to whether you may or may be able to repair the original tissue, or you may have to entertain the use of a graft. I'm going to go through some of the sports med applications in the knee and in the shoulder, particularly the patellofemoral joint, so some condylar defects, and then the Hill Sachs in the shoulder. This is a patient of mine. He's a college Pepperdine College professor And he is he's about 3 weeks out from a procedure where I used two HA S-core implants on his trochlea, and he had significant patellar catching and locking prior to the procedure. And he's basically stating here that just it feels smooth. He's able to get all the way around without any significant pain. So it's a very durable, strong repair. Our rehab specialists here were able to get him to progress quite aggressively because his symptoms were so minimal. I'll show you some images of his surgical procedure in just a moment. But this patient wants to go back to snow skiing, and what I found is that these trochlear defects, this patellofemoral joint osteochondral disease, is very unforgiving, and so this is really given me a lot of confidence in moving forward with this procedure. You can see the radiographs here of the implant. He had a previous high tibial osteotomy, so his medial pain was resolved, and as I said, continued to have this patellar locking symptoms. You can see I used two implants here, sort of on each side of the trough of the trochlea, and you can see from the side kind of how it appears. And this is a arthroscopic image of. You can see on the upper left, I fixed one area, and then I went ahead and put a second area here. This is just a bone tamp that's just kind of pushing down the graft tissue. The implant is obviously subsurface and in the bone. And so these are some images of the final reconstruction and some dynamic ranging of the patellofemoral joint. This is another patient of mine that's a professional volleyball player, sand volleyball. She had this acute osteochondral fracture defect of the condyle that was irreparable, and you can see some of the steps here showing the creation of the guide tunnel with the good bleeding bone. And after the reconstruction, and then once the tourniquet was down, how it looks over here. This one was a 7mm implant to fix that area, and this is the patient has done very well post procedure. She's achieved a Tegner level 10, which is the highest level of activity on that scale, and she's really been able to perform. This is about, I want to say, 3.5 months post procedure. She was able to start playing in the sand at about 6 months, and then competed in the Olympic trials. That's her making the dive there on the right, and taking the hit over there. So she's done really well, and probably needs her other knee done. Another patient is a retired Marine, 31-year-old male. He has this lateral condylar defect. You can see some of the bone damage, the bone edema. I used a 7mm implant on this patient. This is the reconstruction on the lower image. And this patient also has done quite well. He's playing basketball recreationally, and he's part of the Forest Fire Department fighting fires here in California. His KOOS score looks really good. Now, this patient at about 4 months post-op had overdid it in physical therapy and had some patellar plica type symptoms. So I brought him back, and we were able to get a second look just to clean out some of those adhesions. And it looks pretty good at 4 months. There's a good incorporation of the tissue to the surrounding tissue. He didn't have any clinical irritation in this part of the joint, and it feels quite smooth. And this patient has continued to do well. This was nice to see at just about 4 months post procedure. There's no adjacent surface damage, and it looks quite good. This is another application in a Hill-Sachs defect. This patient is a sheriff recruit in the academy. He had a prior Bankart tear in high school or college, and then was a recurrent dislocator. You can see his Hill-Sachs defect in the posterior superior humeral head, and it was engaging arthroscopically. He was very, very loose. I had to fix him all the way around. So I was able to repair this humeral head fracture defect, this Hill-Sachs defect, arthroscopically. And here you can see the guide pin coming in. This is kind of looking at it from the top, and then that's the implant coming down in directly into the defect. And this patient has done well. He really recovered very nicely, and he's joining the academy again this next month. And his clinical scores look great. He's got no pain, no mechanical symptoms, and he's looking really good. There's foot and ankle applications. We'll talk about the MTP joint and the talus. This is a patient, 69-year-old electrician. You could see some of the early hallux rigidus signs, but also this significant bone involvement here of the bone failure in the met head. And so an 8mm implant was utilized to reconstruct that, to fix the bone. This patient, he was non-compliant. The case was done on Friday. He hiked for 3 miles on Sunday, went back to work on Monday, took his boot off, wasn't using a crutch. And then at his post-op visit 5 days out from surgery, he scheduled his other foot. So, and this patient has continued to do well. It's a little bit closer look at the implant in place. This is some open pictures, just showing the overall reconstruction, the placement of the guide pin into the center of the metatarsal head. Some fluoroscopic guidance was used, and you can see the reconstruction of the metatarsal head looks quite nice there, and some of these other steps. This is a talar osteochondral defect in a 47-year-old patient of mine that recurrent ankle instability. You can see the defect on the sagittal view of the talar head and the axial view. This is my just a spinal needle getting the trajectory right. Here's the countersink reamer prepping that area and getting down through that diseased bone. And this is how it looks radiographically. There's the implant. There it is from the side, and that's the reconstruction intraarticularly with the tissue soaking up some of the blood from below. This patient has done quite well. She is basically fully recovered here. This one, I want to say this is about 6 months out, maybe 5 months. But you can see that I'll speed it up a little bit here. She's basically doing some heel raises without any problems. Her range of motion is good. There's no mechanical symptoms. This is just a closer up look at her ankle. It looks quiet. The thing I've seen in these patients is that there's just a quiet look, appearance to the joint. That's my incision here for the kind of accessory anterolateral approach to put that guide wire in. And then the other incision is for the ligament repairs. So she's very happy with this repair. These are the indications for use that's on our label. It's relatively broad. It's all based around fracture, repair and reconstruction, adjuvant procedures as well. This is a short video just showing some possible adjuvant procedure options. Some surgeons have talked to us about. Obviously, once the bone is fixated, it's still up to the surgeon to figure out how to reconstruct everything if there's some irreparable tissue. This is a cellular dermal graft that's prepped. It's making a slot for the driver. The implant has these fenestrations. This is a suture that's designed appropriately, and you can see how the graft is placed to the appropriate, basically the implant will be placed into the bone simultaneously, and then the graft will be affixated to the anatomic location. You can see this implant system is done over the guide wire in one piece. And then there's obviously other options depending on surgeon preference about what they want to do to fully reconstruct this tissue. Oops. Just some of my clinical observations. We're less than 2 years out from our first patients. We have less than 300 patients. In my hands, for my patients, they are a variety of patients ages 27 to 76, ranging in activity from pro athletes to weekend warriors. I have some workers' comp patients, military patients. About 30% of the patients are failed microfracture or other procedures, other previous procedures. Cartiva revision has been performed. It's a versatile procedure from a surgeon standpoint because it's relatively easy to do over a guide wire once you get the trajectory, but it's applicable to circular and non-circular defects and contiguous defects. I've done a number of them. When you're scoping the knee and you see involvement of multiple compartments, especially the patellofemoral joint, it may be able to be addressed. And most of these have been able to be done minimally invasive. It's bone preserving and a single stage procedure. You can fix the patients, and at that index procedure, these are all the different anatomic locations that I've reviewed. We've done some elbow cases, a number of MTP joints, talar defects have been performed, and it's applicable really to any joint that has these fracture defects or osteochondral defects. Questions? Thanks very much, everybody. I do want to thank Ben and Josh and everyone at Genesis Ortho for helping put this together. And
yeah, Dr. D, anyone listening, you can use the raise hand option at the bottom, and then I will unmute you. You can ask your question. We do have one in the question and answer box, Dr. D. I'll read that to you. It says, Dr. D, you have shown very impressive results. I wonder on the likely results that would have been obtained from conventional implants in your experience. Please compare your experience and indicate your overall success rates with Subchondral Solution implant.
That's a great question. Yeah, I mean, I've been all of us that have been in practice for a while. We see what happens to standard of care procedures where you see these patients back, and our own patients. Like I said, I've had some failed debridement type patients, failed microfracture, and those are the typical procedures right now. From really what I've seen, that impresses me is the amount of pain relief early on with these patients, even before they start weight bearing. They've that engorged bone is a source of pain often when the bone fails, and bone hurts. And so I've seen that they have very rapid relief of pain, and then they mobilize relatively quickly, much quicker than other procedures that I've done. Patients are not human petri dishes. We want the goal is for a improved, versatile, functional result, and that's what I'm seeing. Should I go down some of these other questions that are typed in here?
Yeah, I'll go ahead and read it. Dr. Benson says, let's assume you have a 4 millimeter defect. How many millimeters larger is the implant than the defect?
Great question. Our smallest implant is 4 millimeters. I've had some defects that small. We've used down to 4 millimeters. The threads do extend slightly on each side. If it's a they extend 1 millimeter on each side. Yeah, certainly, if it's a defect that's on the periphery, for instance, of the talus or less contained, you probably want to cheat in a little bit. But it's certainly applicable.
Okay. Next, Dr. Cottam, can you do this all through an ankle scope without accessory incisions, or do you just enlarge your portal site?
Great question. On the patient that I showed, it was a mid anterior lateral talus. I did use an accessory portal, cephalad to my typical anterolateral portal. I can't remember if I ended up connecting the two, but you're just to get to the correct trajectory, you're just in front of the tibia, and you're obviously have the ankle in distraction and able to cheat it right past the distal tibia. So I don't have a lot of experience with posterior portals on the ankle. We were working with some surgeons that do, and so it all depends on what you can access, obviously. But so far, it's pretty versatile.
Another question, Dr. D, is what type of tissue is growing into the skin graft?
That's a great question. We know that as the cadaveric study showed, the mechanical properties of the graft are very stout and strong. We do know that the acellular dermal graft has good biologic incorporation and healing in other joints, in the shoulder, in superior capsule reconstruction. Some of the retrieval studies from glenoid resurfacing and superior capsule reconstruction show good vascular and cellular ingrowth, including chondrocytes migration into portions of the graft that are under compression. So we don't have biopsy results, but we do know that it's a functional result. Patients are doing well functionally, and radiographic follow-up. We're doing X-rays. Show a very stable fixation and ingrowth of the bone to the implant, and really not any adjacent changes on radiographs. So.
Okay. Another one, what is your experience with talar shoulder lesions?
That's a great question. I mean, as most people know, that a lot of these osteochondral defects are on the shoulder. We've done some things in the lab, seeing how close to the lateral wall we can drill. You really have to angle it in just a little bit, maybe 3 degrees, 3 or 4 degrees, to miss that lateral wall. In the knee, when I've had defects, there's a number of patients that I've done where the osteochondral defect, the missing tissue that's more superficial, is larger than the bone damage. So I've used a larger graft. For instance, if I'm using a 7 millimeter implant, I'm using like a 10 graft to reconstruct that missing tissue. And so I think that's certainly an option with these uncontained areas where the screw implant is mainly focused on the bone, and then the surgeon will elect to reconstruct the lateral wall, with what appropriate allograft they choose.
Adam Finn asks, do you always need to cover the implant with an allograft in place of native cartilage?
I mean, that's a great question. Some animal studies have been done with titanium and hydroxyapatite coated implants. that were not used with a graft, and there was some nice healing of neocartilage over the top of the implant. That was in a sheet model. There's been some cases, certainly the smaller ones, like 4 and 5 millimeters, that have been used in conjunction with like a contiguous lesion that's larger, because a lot of these lesions are narrow and long. So in my opinion, as long as it's relatively contained and you're really focused on fixing and addressing the bone, you're really getting like controlled bleeding. You're getting bleeding from the marrow, but stabilizing at the same time. So I have done some cases without any sort of allograft, and patients seem to be doing well.
Dr. Cottom asks, do you add biologics to the dermal grafts as well?
I have not. Certainly that's an option. I know people are doing that. There's a bunch of research on orthobiologics and which ones are more amenable to healing, accelerate the healing. In my practice, I've used some of the amniotic tissue-based injections, not directly with this procedure, but it does seem to add some cushioning to the joint, and it's like a super duper joint lubricant. But I haven't specifically done it directly with the graft, but I think that's a great idea.
Dr. Benson, have you had any patients that have had an adverse reaction to the implant materials?
No, I have not.
Okay. In the chat, we have Richard asked, thoughts on freiburgs, head osteotomies with concurrent use of S-Core?
Yeah, I know that there's some foot and ankle specialists that have used it for freiburgs. I don't specifically have that experience, but certainly, the sizes of the implant lend themselves to that, and we've been really seeing some the feedback from some of our foot and ankle specialists are seeing some really nice results.
Scott is asking, what graft are you seeing used with it most for the MTP?
I would say probably the acellular dermal graft. The graft that I've used mostly is 3 to 3.5 millimeters thick. Some surgeons are using 2 to 2.5 in the MTP joint, but also using the 3 millimeter, and overstuffing the defect. But that would be the most common that I've seen.
Okay. Brad's asking what thickness, which you just answered, was utilized, and how does a system or technique allow for height variables?
I'm sorry, for which variables?
For height variables.
Yeah, I mean, every turn, one revolution of the screw advances at about 0.75 millimeters, and certainly you can really dial in the reconstruction level. I mean, when we're prepping it and measuring it, I didn't show all the steps. Obviously, we're using a ruler, or I'm using a ruler, measure twice, cut once, and so we know that the implant is going to be well within the bone based on measurements, and the graft typically will be a little bit thicker than the native superficial layer, and but you can really dial this, literally dial it in to the correct depth. And once you remove the driver, you can if you're certainly do open procedure, you put your thumb on it, your finger, you can put the driver back in through the graft and adjust the level. But it's it works. Yeah, and arthroscopically, like I said, also you can use these bone tamps and really get a nice feel for the level of the repair versus the surrounding tissue.
Okay. Dr. Cottom has another good question. He says, Cartiva has not done well. Why would this graft perform better with the forces applied through the first MTP during gait? And so how many first MTPs do you have data on, and what has been the initial outcomes? And how long is your follow-up on these lesions?
We have about, it's less than 2-year follow-up. I don't know the total number of MTPs. It's less than 50. Most of the rest of the cases are knees and other joints. I don't have direct knowledge of cartiva in my hands, but from what I could see from the reports, even though the cartiva material is similar biomechanically to native tissue, it doesn't have really a good way to fixate to the surrounding tissue. It's press fit, and I think that's a problem. It's got lubricating type properties. I think the S-Core implant, the way it works is, I mean, it's obviously threaded, so it's very strong, and it's got secure fixation to that surrounding bone, and the way it's performing is that graft is obviously allowing a sliding surface to transmit those forces down through the tissue, and the implant is in a way shielding and protecting that area and dissipating forces. That's the way I've seen it work in the knee. As I said, we don't have more than 2-year follow-up, but we are collecting the data, and so far everything looks really impressive. I mean, patients are feeling good and mobilizing. There hasn't been shown to, we could see our implant because it's metal. We're taking serial radiographs. There's no subsidence. There's very, very strong bone and growth. The other thing that we think is important is when grafts are used there, it helps seal out the synovial fluid. So it actually contains that area. So it seals out the synovial fluid, but it contains the marrow contents from below. And I think that's why, that in combination to the hydroxyapatite plasma coating, that accelerates osteointegration. And so I think all those factors, mechanical lock and bioactive surface, really make it a strong fixation.
Okay. That is all the questions I'm seeing on my end. Josh, I'm not seeing any of the hands raised that may be on your end, if you see any. So if you do see any, go ahead and speak up.
Nope, nothing on my end. Dr. Silverstein had a question on freiburgs, head osteotomies with concurrent use of S-Core.
Yeah, we got that one.
Okay.
We answered that one. Well, okay. Well, if there are no other questions, we appreciate everyone jumping on tonight. We had on one of the last slides, if there's anyone here that wants additional information about utilizing or carrying S-Core, please reach out to us. There's our email right there, sales@genorthopartners.com. And then we will get back with you as soon as possible. But we appreciate everyone's time tonight. Dr. D, thank you again for jumping on tonight. And make sure there's not one more. Yep, there we go. What if we want to try it, Dr. Cottom? We'll reach out to you, and we'll get you taken care of. So thanks again, everyone, for jumping on tonight. Please let us know if you have any questions. And everyone, we hope everyone has a good rest of the evening.
Thanks, everyone.